physiotherapy approach, Dr. Demoreau invented the ART brace, a modern alternative to the traditional plaster cast brace that enabled direct correction on a patient. Serving as a president of CIRR and a former president of SOSORT, he has encountered a variety of established physiotherapy techniques, allowing him to analyze them through the biomechanical lens. After publishing research on how braces function, he collaborated with Tony Betts today to investigate the mechanism behind exercise specific to each validated physiotherapy method. Beyond focusing solely on methodologies, his objective is to equip physiotherapists with the knowledge to select the most suitable exercise for individual patients and identify any potential conflict between different techniques. And our special guest today for the 50th Lyon Master Course monthly tutorial series is Tony Betts. He's a highly specialized physiotherapist. He worked at the Royal National Orthopedics Hospital for over 30 years, one of the largest scoliosis surgical unit in Europe. During this time, he worked with German Schroth physiotherapists and with Dr. Minmeta over 15 years. Tony Betts helped to develop the Minmeta side shift therapy, expanding its use, modifying its approach to 3 dimensions, although Minmeta, through the casting of the young children and the EDF method, was aware of the rotational importance and the scoliosis in a scoliosis condition. Tony Betts was founding member of SOSORT. He is an honorary spinal teacher of the University College of London of the Master Spinal module, as well as teaching courses nationally and internationally. He has developed post-operative spinal surgical exercise program. He has taught regionally and nationally on the subject of assessment and exercises of the lumbar spine for conservative and post-operative care. Perhaps he will be back for telling us more about these topics as well. Prior to physiotherapy degree, he completed a degree in physiology and psychology at Lancaster University, working on proprioceptive organs on insects, a very interesting topic. He have also completed the postgraduate degree and applied muscle physiology, integrating modern neurophysiology into scoliosis-specific therapy with biomechanical principles in passion. So we welcome both lecturers today. This is a very unique presentation with very unique experts. So thank you so much for everyone to join in. I'm going to disappear for a minute, and then we let Jean-Claude take the microphone first, and Tony will take the lecture part 2 after Jean-Claude finished. The questions in a Q&A board during the lecture, please, anytime. Thank you. So you share the screen.
Thank you. Yes, thank you, Andrea, for this kind presentation. This one. This presentation today follow presentation we do last year's with mechanism of action of braces. And discussing at the SOSORT with Tony, we think that we can do also the same for PSSE for the exercise. And if we define 24 mechanism of action for bracing, with literature review, we found a little less, 20 mechanism of action for PSSE. So the first part of this presentation is the mechanism of action to correct the curve. We have 10 mechanism of action: mobilization, the modeling, kinetic chains, axial pulling, rotation along the z-axis, thoracic correction, lumbar correction, respiratory derotation, correction of L4 tilt. You know, we have two lumbar curves, scoliosis, and also sagittal normalization. So the first is mobilization and flexibility. And this is very important to choose the exercise. For instance, if you have a collapse, I will share the laser pointer, perhaps you see better. If you have a collapse at the apex of the curve, it's very difficult to open the concavity at this level. And so the Schrott was done for this type of scoliosis more or less under 100 years ago. And you can open only with modification of the limit vertebra. If you have a lower curve under 40 degrees, it's possible to work directly on the apex of scoliosis. So this flexibility at the apex or at the limit vertebrae can change totally your physiotherapy. The first method, PSSC, CLAP is validated, was for quadrupedic position. You know that in quadrupedic position, you don't have, it's an anti-gravity position, so you have more mobility at the disc and facet level, and it's a very good solution for scoliosis, not only before surgery, but also as a preparation for the correction of the curve. One incompatibility is that the mobilization is better with anti-gravity posture, lying posture. With verticality, you can less mobilize the spine. Then the second mechanism of action is a sinking mechanism, we can say the modelization. You know the Schrott concept, many methods are using this Schrott concept with a pile of parallelogram at this level, asymmetric parallelogram. And it could be a solution. We prefer, with the Lyon method, the hyperboloid, one curve or two curves. It's not important, with stability of shoulder, pelvis, and eventually thoracolumbar region. This allows, the advantage is that you have only one z-axis, and you can only, with this concept, with this modelization, work in detorsion. It's not possible to work in detorsion with the block concept. So incompatibility, you work in derotation with the block concept, and for detorsion, you must use the hyperboloid concept. Second, the kinetic chains. We can work in closed kinetic chain. This is the pole of the Schrott, the hanging position, the Wonder Woman posture, and quite many methods are using this closed kinetic chain because there is more mobility at the level of the spine. But the Lyon, for adolescent, not for adult, for adolescent, prefer open kinetic chain. This is to work more on the extrapyramidal system. And some methods, Dobomed and Fitz, are mixing exercise in closed kinetic chain and exercise, like the Lyon method, in open kinetic chain. And this is the advantage. The disadvantage is that the Lyon method is very, very expensive. It's not possible to work in open kinetic chain. And the Lyon method is very, very expensive. And this is the advantage. The disadvantage is that the Lyon method is very, very expensive. The advantage of this open kinetic chain, as I say, is that you can stimulate the origin of the scoliotic curve. This is the extrapyramidal system, the motherboard of the computer. It's not possible in closed kinetic chain. Closed kinetic chain, you are better for curve correction. So you must choose one or another situation. Fourth, the axial pulling translation along the z-axis. This was the experimentation of Lewis-Serre. When you push, you create scoliosis. When you pull, you correct scoliosis. So this is why the self-elongation, auto-elongation, more or less is the more consensual exercise with all PSSE methods. But you will see what you do when you lengthen in elongation. The problem is that there is a diminution of the curve, diminution in the frontal plane, but also in the sagittal plane. So you have, with this self-elongation, you have the risk to increase a flat back. It's possible to avoid this risk when you work in closed kinetic chain. You ask for elongation, but you limit this elongation with a buzzer at this level. And so you see with this flat back, it's not so easy, but you can try to ask a little kyphotization and lordotization. So it's also possible to mix both method, elongation, axial elongation, pulling, and the sagittal normalization. This is the semi-hanging posture of Schrott. So it's okay for lordosis, but you see that there is a risk of to increase the flat back. Alors, thoracic kyphosis, it's not always a good solution. With thoracic kyphosis, you increase the load on the intervertebral disc, and when you make a derotation, for instance, there is a risk at the intervertebral disc. So you must choose with many indications with your scoliosis. If you will work in derotation, in this case, it's not the case to increase thoracic kyphosis. For rotation along the z-axis, alors it could be rotation, it could be detorsion. Detorsion if you have stability on the shoulder and the pelvis. The Schrott, there is no stability on shoulder and pelvis. You work with shoulder and pelvis. But with, for instance, Fitz and Dobomed, you have a stability of shoulder and pelvis. The same for the Lyon and the Shift. Characteristic of rotation along the z-axis is the Fitz method. It's very interesting. The work is on the spiral chains. On the concavity, you must lengthen the concavity. This means with myotensive techniques, you can lengthen the concavity and work actively, voluntarily on the convex spiral chain. It's a difficult method, but it could be some indication. And remember what we say before is the origin of scoliosis. First, you have deformation of the rib cage. Second, the disc serves this. The beginning is at the level, at the rib cage level, and working with a spiral chain could be for some patients a very good solution. So you see sometimes in open kinetic chain, in closed kinetic chain, it depends if you have more or less flat back, the angle the problem of discal degeneration if you apply together flexion, thoracic flexion essentially, and rotation. So this is really to avoid for scoliosis. There is a sort of incompatibility at this level. And sometimes it's better to maintain, to avoid too much thoracic kyphosis and to maintain the load on the facet joints. Correction of the curve, we have seen this axial pulling, and we must divide the thoracic curve between T2 and T10 because you work with the ribs. And you see that the contact of the ribs is exactly at the level, the intervertebral disc level. So this is very interesting because remember, first rib cage, second intervertebral disc, and finally the vertebral body. So with physiotherapy for curves between, we can say 20 and 25, 30 degrees, it's important to work directly at the disc level, and it's not exactly the same mechanism of action. And under T10, we don't have no more contact with the ribs, so we work in mechanical detorsion. We will see that the main exercise is a side shift. It could be the muscle cylinder for Schrott for important curves, but quite all other methods, and also for bracing, we use quite always the shift under T10. And we have also the apical derotation. We will see the difference between the Schrott oriented breathing and the Lyon method working in expiration, because we have more mobility in expiration. So the Schrott thoracic correction, Schrott pattern. So you have first an inclination of the axis of the spine. Remember, this type of scoliosis, you have the collapse at this level, and there is no mobility at the apical level. So you can work only with the shoulder and the pelvis. So this is the principle of the blocks. First, inclination of the spinal axis. Then you work with the shoulders, and the same for the pelvis. And so you can realign the spine, not on the gravity line. This is a difference with other methods, but in a way that allow a sort of opening of the curve, not at the apex, but at the level of upper and lower limit vertebra. There is also the mirror, but Tony will speak about this. So the problem is that there is some incompatibility between this inclination of the axis of the spine and the stimulation of the extrapyramidal system. You stimulate better, there is a low risk of low back pain, of lumbar spine injury if you work in a vertical position vertical alignment of the spine. So the modelization of the Schrott first inclination of the spinal axis. So you can give correction at the lumbar level with the pelvis, and the same with the shoulders. So you modify the inclination of the upper limit vertebra. Here you don't have any mobility, and then you can realign the spine on a vertical position. So apical collapse, you cannot open the concavity easily. You can work only with shoulder, pelvis, or the lower limit vertebra if you have two curves. What we do when we don't have collapse is you have the choice between bending and shift and translation. With the Lyon method, we prefer the bending because we open the concavity. We open the concavity at this level. If we use the translation, there is a constant volume, and we must modify after. Yes, we push the apex online, but we must give a rehorizontalization of the upper limit vertebra and the lower limit vertebra. So we prefer the flexion with the Lyon method. With the shift, the side shift, it depends. Sometimes if there is a good mobility, it's also possible to use translation at the thoracic level. And you will see the correction with the coupled movements. Coupled movements, this means that in the sagittal plane, we maintain the sagittal normalization, and then with the flexion tool, the bending tool, we can open the concavity and realign the pelvis and the upper part of the spine. Lumbar translation if we have two curves. So usually I use, it depends the importance of the angulation, but if it's possible to open the concavity, I prefer the bending between T2 and T10 and the translation between T10 and L5 for the lumbar and thoracolumbar curve. Like the side shift is exactly the same principle. Sagittal normalization is important if you want some coupled movements, because when you have the sagittal normalization, you have the same load, you divide the load between the disc and the facets, and you have the maximum of mobility in the frontal plane for the bending. This is why we use this sagittal normalization. We don't use rotation, so there is no problem with kyphotization, thoracic kyphotization. You will see after what is exactly a coupled movements. This is an example of exercise with level stick. You create kyphosis, and then you can translate easily with a flexion. Is not exactly a shift. You see there is an inclination of the shoulder during the movement. It's really a flexion. Another possibility, more passive, directly with the physiotherapist, who is working in kyphotization and flexion. You see the flexion movement, and slowly at the end he can give some derotation. It's also possible to mix a little derotation. Then, for instance, at home, you can control the rotation. Is not really the rotation. There is no load on the disc. and you ask to maintain 20 seconds, if possible, in this opening the thorax concavity, and then relax. With the Lyon method, we ask 10 minutes every day for the patient, because the repetition, daily repetition, is very important for the efficacy of the exercise. This is meta-analysis of all in vitro experimentation for the couple movement. And you see the difference between first lateral bending, what we do at the thoracic level with the Lyon method. You see that we have a coupled axial rotation of quite 50%, between 40 and 50%. If you begin with axial derotation, you have only 20% of bending, of lateral flexion. So it's better, naturally, to work in the frontal plane. First, sagittal normalization for the mobility. Second, you work in the frontal plane, and you have automatically 50% of derotation without risk at the intervertebral disc. You don't create a significant load at the apex of the intervertebral disc. For the lumbar region is different. We don't work with the ribs. And for the Schrott, it was a muscle cylinder, so always the inclination of the spine. And you see the translation, it's also a translation, but with this inclination. So you have here the mechanism of translation. You can use cushion. There is also, you have seen the elongation together. So this is the classical muscle cylinder. I pick this on the internet to show what is the exercise. So you see the stabilization, the patient is pushing L3 on the midline, and then you have the realignment of the spine at this level. You can also control a thoracic curve. It's possible to open together the lumbar and the thoracic curve, and also always the self-elongation you have seen on the computer. In a lying position, you understand better the muscle cylinder. It's we do the same with the Lyon brace and our shift. And the difference is with the brace is more easy because we have a concave wall at this level and we have a push-up. Only with physiotherapy, this is a very good solution. You see the translation of L3, you have the opening of the concavity and also the core muscles strengthening. You can do together muscle strengthening. So the lumbar correction for us, we maintain the sagittal axis, vertical axis on the gravity line, and simply we create a translation, a shift on the midline, more or less. We can work also with the under T10, with the lower part of the curve, and eventually we can realign the thoracic curve on the lumbar curve. We do this in a sitting position. It's more easy to work with stabilization of the pelvis. Then we control pelvic anteversion and lordosis, and we ask to translate, to make the shift. Also, like the Schrott, with a little elongation, self-elongation. And this, the origin, Tony gave me all this indication. It was the beginning of the shift method of min-meta. It was Arthur Standler, 1929, so before Ponseti and Weinstein. And the idea was to decompensate. There is a decompensation with scoliosis, especially with collapse, and the idea was to compensate, recompensate the curve with a shift and eventually the plaster cast. The idea was to rebalance the spine muscles activity. So you see the compensatory Standler, the alignment, and the shift here at the thoracic level. And also you can work the same compensatory shift at the thoracic and the lumbar level. The idea is realignment, recompensation of also with ligaments and muscle on concavity and convexity. So min-meta stabilize the correction with this side shift, sometimes in a sitting position like we do, stabilization of pelvis, and also in standing position. And what was very original, I must say, it was the repetition every hour of the exercise at school, at home, to really obtain tensegrity between concavity and convexity without brace, naturally. So each you work on the pelvis, and then with the side shift for one curve you can realign the spine, and for also you can work only in the frontal plane with Tony work on the 3D aspect, so there is also usually a sagittal normalization, sagittal control, and together with a coupled movements, it's like the Lyon method, you can realign the spine and work on the tension between concavity and convexity. So for a double curve, so first you work with each at this level, at the pelvis, and then with translation. I must say that for bracing, many CPO prefer translation also at the thoracic level. So it could be a discussion. The advantage of flexion is that we open the concavity easily, more easily than with translation. So attention, with the muscle cylinder, it's not exactly the same position of the pelvis, exactly the contrary, with the shift, side shift, and the muscle cylinder. Respiratory derotation, it's very interesting. With the Schrott, the idea was with inspiration, total inspiration, you can obtain derotation, internal derotation, through the concavity. Our experience with the Lyon method, perhaps the difference is due to it's not the same scoliosis. Schrott scoliosis were important scoliosis, more than 60 degrees usually. And with the Lyon method, we use the brace for such important curves, and we prefer with physiotherapy, Lyon physiotherapy, work you see on this detorsion, because with expiration you have more mobility and you can use an external manual detorsion. So you see the difference with inspiration, angular rotational bracing. You see the difference. You have a diminution of the sagittal curves. With the sagittal normalization, here expiration, you see that you increase the curves and you can better derotate in expiration. So it's possible naturally to mix, and the Dobomed, for instance, use both inspiration for internal derotation and expiration for external manual derotation. It's possible to mix both mechanisms of action. The L4 tilt correction is specific to the Lyon method, more or less specific to the Lyon method. It's the same for adult patients when you have an imbalance toward the convexity. So opening the concavity increase this asymmetry of ligaments between the transverse process of L4 and the sacroiliac articulation, the iliac crest. And the idea is to work on opening the iliolumbar angle at this level. This means to lengthen the convex ligaments at this level. So you have some exercise, and there is incompatibility between lengthening these convex ligaments and open the concavity. You cannot do so. You can make both exercise, one to lengthen the convexity, the other to open the concavity. Yes, but sequential, not together. It's not possible together to have the same. And you see, for instance, one exercise. The idea is to lower the convex iliac crest and to lift the ribs on this level. So you lengthen the ligaments, and you ask always 20 seconds of corrective posture. There was another exercise, but it's not important. Sagittal normalization. Sagittal normalization is very important for lordosis, to maintain lordosis. You know that the prognostic of scoliosis in adult life depends more on the sagittal plane than on the frontal plane. So usually the work is to maintain lordosis and also kyphosis. But remember, sometimes if you want to work in derotation, especially with brace, it's less important for physiotherapy, but also if you want to derotate, you cannot give too much kyphotization. So we work on this sagittal normalization to maintain the maximum of mobility in the frontal plane, and also it seems more logical. And we know since Duval-Beaupère, here you have Duval-Beaupère, that there is a correlation sagittal curve. So we know that the pelvic version should be 13 degrees, lordosis, the sacral slope 41, lordosis 63, and kyphosis 48. So we can control on the sagittal profile of our patient if you must work with more or less lordosis or more or less kyphosis. This is the end, the last slide for my part. You see, you can have this, and you see all characteristic. The idea is with PSSE to know. I think it's important, even if you are learning the Lyon method. It's important to know all other characteristic exercise of all method validated, and so you can choose for each patient the good exercise, good indication. Even if I prefer, I use more frequently the Lyon method for a scoliosis, infantile scoliosis, more than 60 degrees. I ask physiotherapists to make Schrott exercise because I think that after 40, 60 degrees, Schrott exercise are better to correct the curve. Thank you for attention.
Thank you very much. And we're going to move on to part 2. Please feel free to add the questions on the Q&A board. So we're going to have Tony turn on the camera and the microphone and share the screen. And we're going to have all the questions for the from the Q&A board. Okay, so if the students, Lyon students, want to come live, they can at the end of Tony's presentation. So we just need your camera, Tony. I think it's coming now. Yes. And the screen share.
Thank you.
Perfect. Thank you. And we continue with part 2, and we meet everybody for questions after. Thank you.
Thank you very much. It's my real honor to be asked to present in this mechanisms of actions. Me and Jean-Paul have talked about this for a long time, Jean-Claude, and it's a real pleasure to try. We've introduced the first concept about the mechanical mechanisms, and we're now going to try and talk about the neuromodulation and how the proprioceptive system works, both to integrate the system to correct the postural and the alignment mechanisms, and how this is integrated within the posture or system of the muscles, and how we can combine these systems together in order to understand what it is that we're actually doing. So we've talked very much about correction of the curve mechanically. And now we're going to talk about the correction of the curve, looking at the proprioceptive system, how the sensory motor training, particularly in relation to the concepts of Lyon, how these common mechanisms related to postural integration within the system, how stability is a fundamental principle of all that we do. And then we're going to look at secondary mechanisms, looking at things like tensiousicity, pain relief and bone mass, how that relates to the different systems of tension and compression, how this is related to sports and functional activity in particular, and what compromise that has, how this is all related to what we call a neurosensory motor reprogramming, how that affects the structure in itself, and then talk about how that's related to how we integrate this within people's everyday activities. So the mechanisms behind which all of these things relates to this kind of this modern neurophysiological concept that we have, that postural asymmetry may well be a central phenomenon as well as a structural local phenomenon. So that the extrapyramidal system is a system that alters proprioception around the trunk, the tone, and modulates how we move in terms of function and everyday. Work by Ryman in particular, as well as from the original extrapyramidal system by Proust in 1899, helps us understand that neuromodulation can help reverse the cycle of recalibrating sensory input, cortical representation, and this extrapyramidal output. So what is it we're talking about? We're talking really about the brain and how the brain modulates these different systems and how our different systems of exercises affect what happens in the brain and how that affects what happens in the body. We know that there's different forms of references and different ways in which the body sort of acts, and lots of different systems now are trying to integrate within this system. So we've got the cortical cerebral system, which is obviously our frontal system, our consciousness system, and below and behind that we have the unconscious system, mainly based around the basal ganglion, the cerebellum, the nuclei in that modulate and place down into the spinal cord that then go into our peripheral system. And it's this system of modulation and of bringing it which we're all trying to work on. Different systems work on it in different ways. In the Lyon method, I'm very much interested in the proprioceptive and skin afferents and how that affects our automated processes, how inputting from this system can help modulate the way the body moves and the way the body works. And we're trying to continuously not just sort of strengthen the body, but actually strengthen the connections between these proprioceptive systems. The Schroff system involves a whole body visualization system where we're trying to use motor neurons, efferent somatosensory visions, bringing everything together, all of our fiber tapes by bringing it in order to bring this system of cognitive processes and helps to modulate that down into the system. With our shift system, we're bringing a premotor control. We're talking about think shift, embody the processes that help with correction and make that a repetition throughout your everyday life, doing it many times throughout the day so that it becomes a habitual automated process, which all of the systems are trying to do. This is all part of a system which integrates into CS, which is really bringing the cognitive processing much more into how we feel, how we think, recalibrating that system and bringing forward this auto-correction process is all the time in order to remodulate how we think and do. So what are we talking about when we talk about the extrapyramidal sensory motor training system? It's a system that was developed here as a concept from the pyramidal system when we talk about how to decorticalize the brain and what happens at different parts of pathways going down. So we know it relates to tone, balance, head and eye control, and fine motor control. So the rubricospinal system is related to fine motor control. That's a coordination of the limbs and the actual muscles together. Head and motor control is coordinated by the tetraspinal control, and that tells us where our head is in space relative. The vestibulospinal system relates to balance, anti-gravity control, head trunk coordination. And the cortical spinal system, which is part of this, as well as the reticular, helps us in our coordination of gross body movements and also breathing mechanisms as well. So all of these are part of a system whereby our brain modulates and controls what's going on with the rest of our system. So this work has been modulated and it's been found out work looking at what motor control and motor functions do. We got postural control, repositioning and disposition and tonic attitudes for voluntary movement. So what we're talking about here is not only how the spine works, but how it actually works and modulate what goes on with the rest of our body. The performances of tasks brings this from the unautomated system into the automated system, and through practice and rehearsal, we can help this modulated system. And these controls of modulation happens through practice and activity. Control of reflexes affects the responsiveness of the affective and the attentive systems, and the control of movement helps our voluntary systems. Oops, sorry. So let's talk a little bit specifically about what's happening in the extrapyramidal system within our proprioceptive system locally. So we have the systems of the Golgi tendon organs, the muscle spindles. They give us the feedback locally in our systems towards what's happening in our spine. And what experiments have found out that if there's a breakage or a link between the feedback systems on tension, pain and modulation given from our Golgi tendons and our muscle spindles, if this feedback is somehow broken, this can lead to the creation of some form of scoliotic deformity. If the body is not getting the feedback from these local modulating systems around the joints and the muscles, then it's more likely to malalign or be out of line. So the proprioceptive systems that happen locally are fundamental to the system of feedback, feed-forward systems that happen from the brain. So actually, what we're trying to do for our exercise is not only just correct the structural mechanisms, we're trying to correct what happens within the modulating systems locally and proprioceptively. Looking at the systems, how do we influence them? We know through our manual techniques and even techniques that involve acupuncture that we can affect these systems locally within a proprioceptive. We affect what happens at the muscle spindle systems. We affect what happens at the Golgi tendons. We can use acupuncture techniques and manual techniques like massage to actually remodulate and influence those systems. And by doing that, we can have effect on actually the cob angles and promote the quality and improve the movement of function with people with AIS. So how is this happening? It's happening at the skin level through our sensory feedback that we get from the skin. So our light touch feedback happens with our Mersner corpuscles, through the stretching reflexes from the Pacini. And also we can modulate this through our exercises by bringing patients into good positions, using our manual techniques to alter the feel and the feedback that the patients are getting, where their positions are and how we try and move them. And we try and place them in positions which maximize and minimize their discomfort and get their muscles in the most better position. We can alter the positions in which we use our muscles to make them more likely to help with things like sagittal normalization. And we can make sure that we can alter the stress and tension of our muscles through our positioning. So we get a renormalization of this proprioceptive system locally. When we're trying to influence or affect the muscles directly, we can use specialist manual techniques to try and alter the activity of our muscles on our concavity sides. We can lead to relaxation, reduce the afferent input, and so that it's easier and more able to move the movement. And we're doing this by trying to alter the proprioceptive quality and feedback of our muscles, reducing the actual concavity tension from muscles that are working too hard, where there's too much proprioceptive input is too high, causing tension and contraction. And as we work and release these techniques, we can then use our exercise techniques to help with the corrective basis on the principles of mechanism that we've just already described. These techniques can be done both transversely across the muscles and obviously longitudinally. They're all trying to reduce the actual muscle spindle overactivity, desensitize the way the muscles are behaving, and reduce the overafferent activity that might be causing the contracture and the changes. And by using these types of techniques, we can help to modulate the system of the afferents proprioceptively so we can build that into our systems. In particular, when we're talking about modulating the system using proprioceptive systems, and this is not my expertise, but I'd like to just, the Lyon method we know tries to modulate the system using not strengthening exercises, but feedback mechanisms through the proprioceptive. And we can do that using the principles of simple modular pendular systems where we're on stable basis from the trunk upwards using axial elongation, using perpetuations across the system. And we can also do it in a more chaotic pendular system using the lower limbs and the legs and trying to create much more disruption in the system. And that disruption is then counterbalanced by the activity of the proprioceptive muscles as they try to recalibrate the system. And that in itself, recalibration, helps the proprioceptive and the postural systems remodulate. And it's by deciding on which parts of it, depending on what type of curve pattern we have, we can modulate it either in a simpler way or a more complex way, depending on how well the patient can cope and modulate those systems. When we're using proprioceptive systems and ballistic activity, we're trying to feed forward into the stretch reflex activity of the local muscles there and helping that to modulate up through the brain. So we're using proprioceptive rebound stretching techniques that actually feed into the muscle system up through the brain and modulate the postural system much more accurately, rather than just thinking about it as an exercise load system, but thinking about it do we modulate the system? What are the great input? We're trying to influence the vestibular system. We can do that in different planes, trying to look specifically at the in the frontal plane, and just making sure that by altering the base of support and the permutations, that the modulation systems and the feedback forward systems constantly working against this imbalanced system of permutation is creating a feedback movement. The stretch reflex afferent systems on the Golgi tendon and muscle spindles are reacting to this, and they're remodulating using mirror feedback and systems. We're hoping to bring that system back to us and helping the body and the brain remodulate where it is in space and work against the asymmetry. We can do this in both planes, as we say, working on one or two planes as we go on, depending on the competency of the actual patient. So that really takes us through to the sensory motor retraining system, and a lot of it based on the Lyon. We're now looking at how these common mechanisms are related to the correction of postural systems. What's really important is understanding and education as part of what our postural perception is. A lot of research has shown that the postural asymmetry is a big problem with people with AAS or any form of scoliosis. It's based inherent within their system. This concept of asymmetry and where the body is in space has been fundamentally affected, or is fundamentally part of what this kind of disease state is, so to speak. So what we need to do is teach people how it is, what their body system is, how it works. And through education, we help to reinforce the cerebral cortex part so that it can modulate down into the basal brainstem systems and going down for our spinal cord and peripheral system. So it's really important they get a good understanding of what it is they do. And we know that the outcomes is related to body care, awareness, quality of life in individuals. And studies have shown that it works really well, that with poor body awareness, if we educate and improve people's perception and motor skills, that in itself has an important component in part of the way we treat scoliosis. So we need to integrate this within our activities of daily living. So that means it's not just an exercise in itself, but we need to make sure that all of the systems and all of the remodulation processes that we've built up now go into what we do. And that means using a repetition of lots of different exercises at different systems that coordinate the body system. This task specific is fundamental to the way we think about modern neurophysiology today. We know that in all forms of exercise and sports-related systems, where and how you exercise is really important, because our body modulates task specific. It remembers patterns of movements together, so that if we don't take the way we move into other systems that are more common to where we are, it won't actually regulate where our body, where our muscle spindles are in relation to our joint positions, in relation to our activity. So we failed to take what we've done into the systems that we're trying to help where the patient is behaving. The epigenetics has shown us that we change the way our bodies work through how we work in our environment. The genes in our behavior, in our muscles, even in our bones, can modulate through our activities throughout our lifetime. That our genes aren't just fixed from birth, that actually they alter through our environment and activity. So it's possible for us to alter the way our body modulates through how we use it. So postural rehabilitation is fundamental, and it's been shown and proven that using scoliosis-specific exercises effective for treatments when it's incorporated into the daily living. So how do we kind of modulate this as a whole system? We've looked at how we've got interventions related to rotational breathing axial load. We've got the concept of autocorrection, how that's related to what happens at the basal ganglion and premotor, and that helps with the symmetrical resetting. Sensory motor reworking is related to our vestibular systems and our eye systems, and they help remodulate or realign our lateral place into a midline recalibration. This concept of think, shift, or remodulating how you think about things is related to postural cueing. The prefrontal cortex with the extrapyramidal circuits help to create this cortical intent, this automatic sensory recalibration that affects our cortical cone. With stabilizations, we get balanced and balanced tone. That works on our systems of muscles very locally, and we'll come on to how we modulate muscles in terms of what type of muscles work. And that's the work of Reinman added to the extrapyramidal system, bringing it all together. When we're talking about strengthening muscles, we know that stabilization is a fundamental part of everything that we do. Bringing forward that work, we know that it's related to what type of fibers we have, either type 1 or type 2. Type 1, we're all very familiar. Low anaerobic, tonal muscles take more time to fatigue, hold us there. Type 2, high anaerobic power, get power, fatigue easily. So we're working on both set of systems depending on what we're trying to do. We're trying to do slow, controlled, tonic-based system exercises, collaborate it with other exercises on top. But we're trying to look into this system together and bringing them both. And that concept of stabilization brings together our big muscles and our small muscles with our realignment together in order to make sure that our strength is not just the strengthening of the muscle systems, but it's integrated with the postural systems too. Systematic reviews have looked at how general core-based exercises help with scoliosis and have found some significant differences in terms of cob angle, better quality of life, and things like that. So we know in specific, just working on core and strengthening at a local level can give us a good input into our regulatory system. When we talk about core, we're talking about it as a link to all our body systems, to spiralization, and particularly to how the large superficial muscles interact as a chain throughout our whole system. You know, core stability is essential to supporting the spine. We can't stand up without it, it's obvious. We need to strengthen the deep stabilizers because they're the ones that control our postural spinal system. So targeting them in particular, but coordinating how they work within the spiral of the whole system helps to keep that balance between how the deeper muscles work and the superficial muscles. Stabilization mixed with the mechanical action helps us hold the body in position and improve our muscular control of our specific muscles by challenging them in very specific positions. Here it's challenging in positions of hyperkyphosis, trying to make sure we modulate the thoracic spine and then place an extended position of movement and control that the patient has to while coordinating all of their body systems. And that interacts that. We've got the kyphosing of the thoracic kyphosis with the actual instability of the Swiss ball. And we're all quite familiar with that. We can stabilize the spine in different planes, so we can look at it more in the coronal plane, looking at side chains, tensioning the spiral system in the side system, using vertebral alignment systems, and linking both this closed chain kinetic system to all the vertebral sagittal plane and the coronal plane to get the maximum opening of the thoracic concavity. And so this mixture of stabilization system and challenging it with the actual corrective mechanisms helps to coordinate our systems together. And McGill systems, which work specifically on spinal strengthening, coordinate quite well with the way we think about stabilizing the spine. So we're now sort of closely related to what are these secondary mechanisms? How do they apply to what it is that we're doing? We've looked a bit about the proprioceptive systems, the afferent, how this coordinates with the postural system, integrates to our everyday life, leads to strengthening. So this is other mechanisms which are related to how we actually change what the body's doing. One of the main systems is the concept of tensionicity. This is the system whereby compression and tension of the body is coordinated. The bones form the compressive alignment, and the muscles and soft tissues form the tension. Where our bodies move in space is a natural balance system that keeps us coordinated and our movement systems well aligned. And we have to coordinate this system of balance, working on vectors, often in lines between angles of 30 and 60 degrees, creating triangulations to use it as an architectural principles to create structure and alignment. And our movement systems and how we use our movement systems should be based on our concept of what we're doing in the whole body and how it's moving as a whole. These musculoskeletals are a tensegrity system. So they use the concept of compression that happens around the growth of the vertebra and the disc with this concept of what happens to tension as we move our muscles and alignment. And so we get this kind of mixed system of holding and alignment continuously working together to give us a system of stability. And so we have to use our systems of exercising to try and promote that a bit better. When we're looking at what happens to the bone mass, we know that compression and compressive forces are really important, and that bone mass is fundamental to actual compressive force and hence the stability. What we find is that bone growth obviously happens very early in our infantile and early onset, that as we grow, the rate of bone mass happens very quickly. It peaks in women and males at different types, and it has a loss over time period between women and males different. When we're trying to apply compressive forces through our exercises, we're trying to remodulate the bone loss system by applying forces at specific points that add compressive forces that mitigate against what's happening to the bone. Bone, as we say, is a piezoelectric element system that it grows depending on the forces that are acted upon it. And different types of compression forces and strain are aligned to what types of forces we're doing. Bone is formed by the compressive forces allowing and the load we apply to it. So whether we're walking or running, these different forces or these different loads will have a different effect on the bone loss. So by applying our principles of exercises, we're trying to mitigate against something which we know is a fundamental part of scoliosis and how it develops through a lifetime. It's been evaluated with mineral density, and much more work has been looking at how bone mineral density values are related to scoliosis, and they're significantly lower than we see in the general population. So targeting this with our exercise is a fundamental part of the mechanisms in which we're trying to regulate or remodulate the spine. How do we coordinate this all together within sort of growth systems? So when we look at sports activities and anticipatory and feedback systems, we know that postural mechanisms are related to how we use the body. Work's been done which has shown how we use the body both statically and dynamically, and anticipate our postural mechanisms helps control our systems. So using sports and active exercises fundamentally in corrected positions is an important part of how we remodulate and use our muscle systems together locally and globally. And it's fundamental that we use this anticipatory feedback and feed forward system through sports to create postural adjustments. Now, it's been looked at very specifically with scoliosis, and the work and studies done by the ISICO group, head by Negrini, has shown that sports participation is one of the most fundamental activities that helps reduce the progression of scoliosis curve. So encouraging sports and active exercises in adolescents is really important when it's integrated with the specific forms of therapy, brace or exercise base. So we're reprogramming the systems through a mixture of ballistic stretching and exercises, through motor control retraining, through the way we think and feel about our bodies, to how we modulate these systems of thinking and feeling. When we're applying it to children, we're also doing this concept of neuro enhancement. So how we use it is dependent on their age, their activity, how much they are able to onboard our instructions. And it's really important that we understand that at different ages, adolescents or beyond the ages of 50 are perhaps much more able to understand this system of neuromodulation than very young. But we can combine simple instructions with activities that place them in perpetuation positions that get into the ballistic and the proprioceptive systems of muscles. We're bringing the peripheral systems together with our central systems of control. And this forms a fundamental part of our motor control training. This has been looked at very specifically with the CS group, and their work has looked at the corrective motor responses, how that's related to self-correction, and their very specific cognitive behavioral approach brings that into. And different forms of therapy use different forms of interaction within the patient to create these changes, and what system you use and how you apply it will depend on it. But we're all trying to work towards this system of neuroenhancement, neuromodulation, instructions to the patient both at a simple and a complex level in order to create a self-correction. Fundamentally, the most important thing for us is time and time consumption. That means not only when you apply the exercises related to the mechanics of growth, but how you apply it and how the patient is able to take that on. So frequency and duration of sessions, daily repetitions at home, all of these types of things are really important. Now, the Schroff exercises on a recent study has shown that perhaps they get a better results in terms of ATR and cob angle, but the Lyon exercise system based gets a more favorable results in terms of quality of life and how the patient feels about their health code outcomes. Now, this is really important in terms of what it is we're trying to do, really. Different techniques involve a different kind of dose response and a different sort of burden in terms of your exercise. And we know this is an important part of how people feel about exercises related particularly to adolescents. So things like Schroff techniques, which are really good, but involve a certain sort of moderate levels of intervention, have to involve a certain sort of commitment to their exercises. And their optimal response is based on how much they commit that and how much they can maintain that in the long term. And these optimum parameter methods are really important if you're trying to get exercise intensity and prescription into the system. You need this balance of, are you trying to help correct the cob angle with what is the quality of life that the patient is able to have. So systems that are based not just on quality of the COB angle corrections, but also the quality of life of the patients are really simple. And trying to get a balance between correcting COBs, but getting good quality of life, good perceptions, good postural control are really important. And with every one of your patients, you need to actually define that and work out what it is you're going to try and create. This study gives some more emphasis to that concept, how Lyon gets a much better response in terms of quality of life compared to some of the other systems in the Schroff, the CS, the core systems, whereby really the input in terms of quality of life related to how much they have to exercise is reduced. And so using the SRS-22, we can show that systems based perhaps on less input and less thing, get better quality of life responses in the whole system rather than systems which are maybe much more based on high intensity systems. So sort of finally, trying to bring this all back together, we're trying to bring the system to what we know PSSE are. We know it's based on these 4 primary principles of patient education, 3D auto-correction, integration into everyday life, and stabilization. We've had systems very much based on the vicious cycle system of Stokes and all of what's happening very locally and mechanically. We now need to integrate that into systems of cognitive references and to what's happening within the brain system and how the brain is helping to neuromodulate the system, both from the point of view of what's happening to the way we think and feel about how our body is, and use our sensory cortical feedback and feed forward systems, but also how our individual muscles are responding to the different types of perturbations or challenges that we're providing to them, and how this modulating system all works together to enhance the 4 primary systems of modulation and control. And hopefully we've tried to show how we can modulate the mechanics of all of the actions of physiotherapy, both from mechanical and from a postural neuromodular system, to create one system of exercises. And depending on what mechanisms we want to use, we can maybe influence very specific components of what we're trying to correct and what we're trying to actually remodulate. Thank you very much.
Thank you very much for both of you. And we are waiting for questions. Actually, they're coming in. This is an incredible tutorial for not just our students, but also for all the visitors from around the world. I will ask Jean-Claude to take the first questions from Italy, and I'm going to read that up, as well as we have other questions coming in, and I'm going to get Tony to see the other ones as well. So until we're waiting here for more questions, I just wanted to let you know that our next tutorial session will be in December. So that's not an open house. So if you sign up to become a student, you can join live, obviously, and join and visit all the other 50 recorded tutorial sessions, which is available for all our students. So I've also received a couple of questions here, but let's start with online questions. From Italy, I would like to know your experience regarding the results of home exercises every day versus exercises with a physiotherapist 2-3 times a week. And it's coming from Italy, from orthotist who is more immersed in the Lyon method. So I will ask Jean-Claude to answer this question.
Yes, with pleasure. Usually in France, we use a session. Each session of physiotherapy is 30 minutes for outpatient. Inpatient, before a brace or before surgery, it's different. We use a more intensive physiotherapy for inpatient. But usually outpatient, the health insurance pay for one session of 30 minutes with a physiotherapist. So we know that to have a good integration of exercise and to modify the cortex, the cortical, the brain, we need more than 60 sessions of repetition of the exercise. So this is why we introduce 10 minutes every day of exercise. Every week, the physiotherapist can choose one exercise or another exercise, could be a progression. But to modify the extrapyramidal system, the automatic system, and the voluntary system, it's necessary minimize. So this is why we introduce this. The other reason is that the Lyon method is connected with sport activity. And you have seen the Schrott method to have the best results on the Cobb angle needs 3 times 1 hour every week. So there is not a lot of time for sport activity. So this is why we prefer this method. I know also that Dobomed, in your table, you can have the usual prescription dose response for each method, but the difference in Cobb angle is not very important. It's under 5 degrees between validated method, but also Pilates, yoga, so some postural methods not specially validated for scoliosis. We have a little modification of the Cobb angle. So for 1-2 degrees, we prefer the quality of life and the everyday repetition exercise for at home. We don't need, with the Lyon method, we don't need the wall bar. So it's more easy. They can buy on Amazon a Bosu ball, a Swiss ball. It costs quite nothing. And they can do the exercise. You have seen the ballistic stretching. We can also teach the mother to control the sagittal position of the spine. So for us, for the moment, for our patient, it's the better system.
Thank you very much. And since we have a side shift expert and teacher here, Tony, maybe I ask the same question and after that I answer from the Schrott background, just because we know that many of our visitors here come from different backgrounds. And as you all noticed and hopefully getting the message from us that the more methods you know, the better it can serve your patient. So we're going to ask the same question from Tony to tell us about how you like to instruct your patients regarding their home exercises.
Yeah, there's two very similar to the Lyon method, and Min Method's original concept was this thing of sort of embodying your correction exercises into a sort of think shift. So that's something that you do all of the time and repetition. So it's not just an exercise, it becomes a habit of posture and movement all of the time. So you move away from thinking about it as I need to now stop to do my exercise, but you think that this is what I have to do all of the time. And I kind of have to remind myself when I've found myself that this is the position I need to be in it, and I'll hold it and I'll maintain it. So we try and do that every day. We use the mirror in the morning, in the evening, so that you're getting that feedback system when they're doing the exercises, they're brushing their teeth or something like that. And then we try and encourage them to integrate it throughout the day, giving them some cues and clues so that they can do that. We've tried to enhance that by using things like EMG feedback systems, and we found that patients have found that it's really useful for them to know what they're doing with their muscles and how how their muscles are feeling, so that they can not only just see what's sort of happening on the inside, but they're getting some feedback of as to what their muscles are doing, and that seems to give them kind of a more a more enhanced belief in the fact that they're doing something that's good, because they can see it on a screen and they can see what their bodies are doing. So doing it regularly, integrating it as a habit, as a posture, and then using tools, like the mirror, but also like things that can give feedback. We tried to use inertia motion units, which give us the concept. Jean-Claude beautifully showed us what happens to the spine in these modulation systems, and we can maybe integrate those sorts of systems to patients in the future that will give them a better sense of what they're trying to do.
Thank you very much. And I'll just have a comment based on, we have so many different background therapists here, how I would approach it with either wearing my Schroth hat or Lyon hat. But let's just put on the Schroth hat for a minute. And I'm guilty of asking my patients to do something every single day. I think it's very important to reinforce the axial elongation and the postural corrections every single day to become integrated into their natural posturing and everyday life. So yes, we do have exercises. I give them the option to choose some of the exercises each day. Start with smaller time frame and increase the time frame as the groups to become more compliant and maintain the improvement, the gradual improvement throughout their growth. We're talking about adolescence at this point, but important to carry that compliance until the end of the growth. So we try to support them at their group sessions, individual sessions, and to become a habit, a good habit, just like brushing teeth. I'm asking them, you don't want cavities, brush teeth, not just do your posture corrections, even if it is just thinking through it or looking in a mirror as you're running up and down stairs. Get the pelvis in the middle, get the shoulders stable, just little things to integrate as soon as you learn it. Because once you integrate it, it's yours. You don't need me telling you every time what you need to do. So we try to empower the patients with the education, the knowledge, and do the exercises to remind those muscles how to work, to remind your thorax how to behave, to remind how to strengthen some of these muscles which don't really have an ideal angles or ideal positions to work. So we are guilty of asking more and more of the patients, and may affect a little bit their quality of life, as they need to be compliant and they need to be prioritizing this part of correction and exercising for the next 1, 2, or 3 years, and become also very compliant with bracing, because we can't win otherwise if we want to halt that curve progression. So it's a little bit more engagement, I would say, in terms of the daily routine. But I actually find the patients who are very athletic, they are more engaged in sports, they're also very compliant. So they will find the time. They will get up early or go back to bed late. To find the time to be compliant is the key component, I think. And of course, there might be some changes in the quality of life, but we try to keep them active, encourage them to stay in the sports and activities, as well as to be compliant with the treatment if the goals are the same in terms of the therapist and the patient, because that also has to be established, what is the goal. So that would be a little bit more information for the question 1. And we're going to move into a question 2, which probably we have been answering a little bit. But we know, I was teaching in Southeast Asia a little bit, and we know that home exercise just not a thing. And it's not easy to ask the patients to do home exercises. So the question from the home exercise, sometimes not all the patients can perform well at home. like axial elongation or side shift? How can you better help them control the quality of their home exercises? And I will ask Tony first to answer this question.
Thank you. Yeah, I think the first principle is to keep it simple, really, for home. So to give the most simple exercise that they can do in your clinic and to let them take that away at home and just apply that simply. As we said, we try and, as much as possible, see if we can get parents involved, and if they can help, I think it's obvious that they get better compliance and adherence with their exercises. But the most important thing is, I think, if you can teach a patient one movement, very simple, per clinic visit, and get them to go at home, it's much more easy for them to control and then add other elements on it than it is to give someone a sort of very complex movement straight away to try and do at home. And I think maybe the failure of one of those. But going back to, I also talked about how feedback systems, and I think we probably need to get better at that as professionals, to give patients things that we know that people love feedback on their watches, how much they're working, what they're doing. Somehow as professions, we need to develop some feedback systems that will allow patients to take their exercises at home, maybe some smart mirrors, things like that, and so that they know what they're doing. I think that's probably the next evolution that will help with home exercises.
Mm-hmm.
Thank you. Jean-Claude?
Yes, I think that the advantage to think PSSE is that we have a larger range of exercise, specific exercise, and you can quite always choose, I agree with Tony, a simple exercise from one method or the other. If it's not possible, we have always with the Lyon method the possibility to brace, to use nighttime bracing, which can work, and add some basic exercise not specific for scoliosis to complete the action of the brace. So we have many possibilities, but surely PSSE, to have this opening on PSSE, it's better to choose a simple exercise to do at home.
Thank you very much. And the questions are pouring in. So there's a short one here. Role of neuromodulation in scoliosis correction. Who would like to take that one?